Patrik Hutzel from IntensiveCareHome.com, where we provide tailor-made solutions for long-term ventilated adults and children with tracheostomies at home, and where we also provide tailor-made solutions for hospitals and intensive care units at home, whilst providing quality care for long-term ventilated adults and children with tracheostomies at home, otherwise medically complex adults and children at home, which includes home BIPAP, home CPAP, home tracheostomy care for adults and children that are not ventilated, home TPN, home IV potassium infusions, home IV magnesium infusions, as well as home IV antibiotics. We also provide port management, central line management, PICC line management, as well as Hickman's line management. And we also provide palliative care services at home. We are also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully for the Western Sydney Local Area Health District, their In Touch program, saving $2,000 per ED bypass service. Basically, if we send a critical care nurse into the home of a client or into a residential aged care, we're saving the healthcare system $2,000 by using our critical care nurses, which cost a fraction of that only. And with an intensive care bed, we're saving even more by providing an intensive care team, intensive care nurse in the community, and we're saving half of the cost of an intensive care bed, which is around $3,000. So in this week's blog, I want to actually read out a study about hospital in the home again. It says the study, I've just seen it last week, says alternative strategies to inpatient hospitalization for acute medical conditions, a systematic review from Jared Conley, MD, Colin W. O'Brien, and Bruce Lev. Now let's read this out. It's just another testimonial, really, that treating patients at home make a lot more sense than treating them in hospital, right? So let me read this out. Key points, and I will link towards the study below. Can patients with acute medical conditions conventionally managed through hospitalization be treated in alternative management strategies while maintaining similar or improved health outcomes, patient satisfaction, and costs? Well, with costs in particular, home care is always more cost effective, always more cost effective. So I don't even know why they're asking that question. The study continues. Evidence demonstrates that a range of acute medical conditions can be safely treated without hospitalization at lower cost and with neutral to positive impact on patient satisfaction. Further robust evaluation is warranted for some conditions and alternative management strategies. In the management of acute medical conditions conventionally requiring hospital admissions, opportunities for health system redesign exists that enable better alignment of health needs with the appropriate setting of care. That's what we've been doing with intensive care at home since 2012, right? No need for hospital readmissions. Even long-term intensive care patients can stay at home, predictably saving the healthcare system millions of dollars, plus the added on benefit of having a free ICU bed. So then the abstract continues. Determining innovative approaches that better align health needs to the appropriate setting of care remains a key priority for the transformation of US healthcare. So it's a US study, but it's the same in Australia and in the UK or in any other country for that matter. However, to our knowledge, no comprehensive assessment exists of alternative management strategies to hospital admission for acute medical conditions to examine the effectiveness, safety, and cost of managing acute medical conditions in settings outside of a hospital inpatient unit. Medline, Scopus, CINAHL, and the Cochrane database of systematic reviews from January 1995 to February 2016 were searched for English language systematic reviews that evaluated alternative management strategies to hospital admission. Two investigators extracted data independently on trial design, eligibility criteria, clinical outcomes, patient experience, and healthcare costs. The quality of each review was assessed using the revised AMSTAR tool. The strength of evidence from primary studies was graded according to the Oxford Centre for Evidence-Based Medicine. 25 systematic reviews representing 123 primary studies met inclusion criteria. For outpatient management strategies, several acute medical conditions had no significant difference in mortality, disease-specific outcomes, or patient satisfaction compared with inpatient admission. For quick diagnostic units, The evidence was more limited, but did demonstrate low mortality rates and high patient satisfaction. For hospital at home, a variety of acute medical conditions had mortality rates, disease-specific outcomes, and patient and caregiver satisfaction that were either improved or no different compared with inpatient admission. For observation units, several acute medical conditions were found to have no difference in mortality, a decreased length of stay, and improved patient satisfaction compared to inpatient admission. Results for some conditions were more limited. Across all alternative management strategies, cost data were heterogeneous but showed near universal savings when assessed. For low-risk patients with a range of acute medical conditions, evidence suggests that alternative management strategies to inpatient care can achieve comparable clinical outcomes and patient satisfaction at lower cost. Further study and application of such opportunities for health system redesign is warranted. It just goes to show that we are just scratching the surface with home health, hospital in the home, intensive care at home. Even though intensive care at home has been around in Germany now for over 25 years, it has been a successful model and evidence-based model in Germany and in Australia, and in Australia since 2012. We have been saving the healthcare system millions and millions of dollars over the years by providing an alternative to a long-term stay in intensive care for predominantly long-term ventilation, tracheostomy care, but also tracheostomy for non-ventilated clients, ventilation without tracheostomy, and so forth. So it is an absolute no-brainer. Now, I just want to make one mention with mortality rates. Some of what we are doing is also palliative care. That means some of what we are doing is end-of-life care, and our clients respond very well to that. They want end-of-life care at home, not in a hospital. Once again, I think some studies suggest that 75% of people want to die at home instead of an institution, i.e. hospital. Less than 15% actually do die at home. We need to get those numbers right. We need to listen to what people are telling us health professionals, and we need to act accordingly, right? And those study like this one, just confirms that an even bigger shift is needed towards home care and not towards hospital care, right? We really need to listen to what patients and families want and put the relevant structures in place. Every industry works around supplying goods and services that clients want or customers want. It should not be any different in the healthcare industry. A lot more can be done at home than people think there is, with the right skills, with the right mindset, and with the right support structure. So thank you for listening, and I will send a link towards the study. With intensive care at home, we're currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are an NDIS approved service provider all around Australia. We are TAC and WorkSafe approved in Victoria, iCare in New South Wales, NIISQ in Queensland, DBA all around the country. Our clients and we as a provider have received funding through public hospitals, private health funds, as well as departments of health. We are the only service provider in Australia in 2024 that has achieved third-party accreditation for intensive care at home nursing. No other provider has created this much intellectual property for intensive care at home nursing than intensive care at home. We are therefore employing hundreds of years of intensive care nursing experience in the community combined. Once again, no other service provider brings that level of expertise in the community than we do. Now, if you're at home already and you realize that you're on a ventilator, tracheostomy, BiPAP, CPAP, home TPN, whatever the case may be, and you realize that your current setup is not working, that your current team is not having the skills and expertise to keep you at home predictably, you feel unsafe and you're going back to ICU all the time, or you have medical emergencies that really makes you worried, where your providers might call an ambulance, that's when you need to reach out to us, because with our intensive care at home nursing experience and with our critical care nursing experience, you will be safe at home and we keep our clients at home predictably. I just want to illustrate one case study here for you, what I exactly mean. Our very first client with intensive care at home over 10 years ago was a client that lived at home with a C1 spinal injury, ventilation, tracheostomy. He had a team of support workers looking after him. team of support workers basically looking after someone on life support. That is insanity in and of itself. And it's dangerous. It's often a death sentence, right? People have died because of this model of care, right? So what happened was the team of support workers, as well as some general RNs without ICU experience, could not keep him at home. He bounced back into ICU all the time. His life was dangerous. And then eventually he got in front of us. Then we, sent a team of intensive care nurses in there, and he never, ever went back into ICU for any emergency admissions, right? That's what I mean by that. If you're at home already and you realize something's not working, you have shifts unfilled, or the team that is looking after you, it's simply unsafe, right? They don't know what they don't know. They don't know what they're doing. Bear in mind, they wouldn't know what to do in a medical emergency. Once again, patients have died because of this. That's when you need to come to us. And you shouldn't be worried about the funding side of things. We've always been successfully involved in the advocacy for the funding. That's also why we're providing level 2 and level 3 NDI support coordination, as well as TAC case management. Our NDI support coordinator and TAC case manager, Amanda Riches in Victoria, as well as Rosie Hammer in New South Wales, have a wealth of knowledge in their team. And I'll put a link in the written version of this blog to an interview that I've done with Amanda a while ago. And if you're an NDI support coordinator watching this and you're looking for nursing care for your participants, please reach out to us as well. Or if you're looking for funding for more nursing care for your participants and you don't know how to go about it and want evidence to provide, I also encourage you to reach out to us. We can help you with the advocacy, and we also provide NDI specialist nursing assessments done by critical care nurses with a legal nurse consulting background. And if you're a critical care nurse and you're looking for a career change, we are currently offering jobs for critical care nurses in the home in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Victoria, as well as in Warragul in Victoria and in Geelong in Victoria. If you have worked in critical care for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care qualification, we will be delighted to hear from you. Disclaimer: because we are offering a tailor-made solution for our clients, which includes regular staff, our clients will have the same staff coming over and over again because they are so vulnerable and so special. It's all about building those critical relationships with our clients, with our team members, and having regular and stable teams. That means if you're looking for agency work where you can come and go, this is probably not the right fit for you on a long-term basis, because our clients want regular staff over and over again. So it's all about building relationships with our clients, and we want to build relationships with you as well, so that it remains a win-win situation. If you're an intensive care specialist or an ED specialist, we also want to hear from you. We are expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in ED for your long-term patients or for your regular readmitting patients with our critical care nurses at home. We are here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, please reach out to us as well. We can help you. Lastly, if you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website, or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and for families with intensive care. Click the like button, click the notification bell, comment below what you want to see next, what questions and insights you have from this video. Share this video with your friends and families. I also do a weekly YouTube live where I answer your questions live on a show, and you will get notification for the YouTube live if you're a subscriber to my YouTube channel, or if you are a subscriber to my email newsletter at intensivecareathome.com. Thank you so much for watching. This is Patrik Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.